Welcome, everyone, and thank you for joining the Children's Hospital Colorado Genetics Virtual Education Series. Today's topic is Updates in Prenatal Genetics. Our virtual education series is designed to be interactive, so we strongly encourage audience questions. Since cameras and microphones will remain muted throughout the session, please submit your questions via our group chat feature. A handout to include instructions on how to access group chat was sent to all registered participants. Our speakers will be happy to respond to audience questions during Q&A at the end of the presentation. Please allow me to now introduce our speakers for today's session. Hannah Elfman, instructor, certified genetic counselor, OBGYN outpatient clinic, University of Colorado Hospital, Division of Maternal Fetal Medicine, Department of Obstetrics and Gynecology. And Kestutis Micke, instructor, certified genetic counselor with Colorado Fetal Care Center with Children's Hospital Colorado, Division of Maternal Fetal Medicine, Department of Obstetrics and Gynecology. Thank you all again for joining us today. Now let's begin.
Okay, sorry, I was on mute there. Okay, hi everyone, I am Hannah Elfman, genetic counselor at University of Colorado Hospital. So Kestutis and I will both be presenting on some updates in the prenatal genetics world. So I will focus on the current options and recommendations for carrier screening, and then talk about cell-free DNA screening for monogenic disease, which is pretty brand new. And then Kestutis will talk about prenatal whole exome sequencing. Okay, so as you all are probably familiar, carrier screening is available to identify reproductive couples who are at increased risk for autosomal recessive and X-linked disorders. Being a carrier is common. We all are carriers for at least one genetic disorder. People don't typically know that they are carriers because carriers typically are healthy and don't have any family history. So unless there's an affected family member, the only way to know you're a carrier is to do this type of testing. Most of the conditions on carrier screening are inherited in an autosomal recessive fashion. So as a reminder, for autosomal recessive, that means someone is affected if both copies of their genes have the pathogenic variant or the mutation. So that's shown in the bottom right with an affected child with that condition. They have two mutations in pink, which means that both of their parents are carriers. So carriers have a copy of a gene that's working and a copy that is mutated. So every time they have, this couple has a pregnancy together, there's a 25% chance child will be affected and a 75% chance child will be unaffected. And they could be carriers or not be carriers for that condition. Other conditions are inherited in an X-linked manner. So these are conditions where the genes that cause them are on the X chromosome. So females are typically carriers for this disorder. So there is a mutation on the gene on the X chromosome that mom has. With each pregnancy, there's a 50% chance she'd pass on this mutation. And so she could have a carrier daughter like herself, a daughter who's affected, or an affected son. And then a 50% chance child is unaffected. When there's a couple who are both a carrier for the same disorder, or females a carrier for an X-linked condition, there are a few options that we discuss in terms of reproduction. Some couples choose to do in vitro fertilization and do genetic testing on the embryos. Others may consider using donor sperm or donor eggs. There's an option to do prenatal diagnostic testing during the pregnancy. The earliest can be done with a chorionic villus sampling around 11 weeks of pregnancy. And then lastly, there's an option for adoption. So in terms of which genetic conditions are included in carrier screening, so typically we want to include ones where the natural history is well understood and the disorder carries a potential for significant morbidity and or mortality. There should be a greater than 90% detection rate or an allele frequency greater than 1% in the population. And then it should be a reliable screen, so with high specificity, sensitivity, and a predictive value. I wanted to touch just on the history of carrier screening because the approach has changed over time and will continue to develop. The screening was initially focused and based specifically on ethnicity and family history, and has now become more population-wide screening. The first screening programs were in the 1970s, again, targeted towards specific ancestries where there were recessive conditions that occurred in a high prevalence in those communities. So in 1971, when we were able to test for carrier status for Tay-Sachs disease, the program came out, and it was a community developed program, so it was considered a great success. So the carrier frequency in the Jewish population for Tay-Sachs disease is about 1 in 30. The incidence of Tay-Sachs was about 1 in 3,000 to 4,000. But then once this carrier screening program started, the incidence reduced by greater than 90%. And then this is compared to another screening program that came out around the same time for sickle cell disease. So about 1 in 10 people with African American ancestry are carriers for sickle cell. There was the National Sickle Cell Anemia Control Act passed, which required all newborns and couples applying for marriage licenses with African American ancestry to be tested for sickle cell anemia. This was not as great of a success, actually considered to be a failure, just in terms of how the carrier screening program was implemented. There was not a lot of education around this. Community members were not included in these decisions either, in terms of how the best way would be to incorporate this screening and how to normalize it as well. Then moving forward, of course, over time, we've discovered more and more genetic causes of these conditions. And then in 1997, the US National Institutes of Health consensus suggested testing for cystic fibrosis for everybody, regardless of ancestry, regardless of family history. And then moving forward in 2009 was the first time that expanded carrier screening was introduced clinically. So we're able to test for hundreds of genes at the same time really quickly and with a reduced cost. Lastly, in terms of methodology, since this has changed as well with the testing, historically, in terms of DNA testing, labs have been using genotyping, and now a lot of the labs are in the process of moving towards or have completely gone towards sequencing. So you can compare genotyping and sequencing to reading a book, where in genotyping, you are just highlighting certain sections of that book. In sequencing, you are actually reading the entire book, reading all the sentences. So genotyping, again, just looking for those common mutations known in the population. But over time, we know that sequencing is really helpful to improve that detection rate and to look for more rare mutations. All to bring you back up to date on what the current guidelines are. So this is from ACMG and ACOG. I just wanted to highlight a few of the recommendations. So the general recommendations is that carrier screening should be offered to all women. So all providers, all clinics should figure out what they want to offer as standard of practice in terms of what panel to choose. Testing and counseling should be performed before pregnancy, if possible. That gives us to do more time for testing. The couple will have options for reproductive decisions. And then lastly, carrier screening does not replace newborn screening. So currently, it's recommended that everybody have carrier screening offered for cystic fibrosis and spinal muscular atrophy. And then for Fragile X, that should be considered based on family history of Fragile X or intellectual disability, or if a female patient has unexplained ovarian insufficiency, as this is a finding that some carriers can have. And then you want to consider further testing if patient or partner has Jewish ancestry for conditions that are more common in that ancestry, and consider further workup for hemoglobinopathies in, again, certain populations such as African, Southeast Asian, and Mediterranean ancestry. So over time, we have lots of options for different carrier screening panels, and there are many, many different labs that do offer these services. So the most standard test would be just for cystic fibrosis and spinal muscular atrophy for those two genes, but there are some panels that fall in between. There are panels that include the trio, so that would include also Fragile X, standard panels, which would include some conditions that are more common in the Jewish population, and the broad panel, which is even more comprehensive. And then lastly, we have expanded carrier screening. So that's over 200 genes or genetic disorders. In the past year, we have what I call expanded carrier screening 2.0. So some of these labs are now offering panels of over 400 different genetic conditions. So expanded carrier screening has been adopted throughout, and the benefit is that it enhances opportunities for autonomous reproductive choice. So we're able to test for these conditions because we know the cause, even though some of them are rare. If a couple knows they're carriers, they have a few options. It's available to anybody, and there's an increasing incidence of admixture in the general population. So many people don't know their ancestry or family history. The expanded panels, especially the biggest one I just was talking about with over 400 conditions, I would say is most commonly used with the REI community. So for people going through fertility treatments and considering IVF. I think that's the target group right now. There are limitations of expanded carrier screening. There are different detection rates based on your ancestry. So for some ethnicities, we know there are certain common mutations that we can pick up. Others, we don't know all of the mutations. There can be a false sense of reassurance if a patient's not identified as a carrier. Some people may think that they had this large panel, therefore they were tested for all genetic conditions, which is not true. And then some of the diseases, some may argue, are not as severe and are not life-threatening, so could increase anxiety. Many of these diseases, too, that are added on these panels can have variable expressivity, meaning that there are many different symptoms or problems someone could present with, but we're not able to predict exactly what that would look like. With expanded carrier screening, there's also an increased chance or likelihood to actually diagnose someone with this panel. So you could be diagnosing them, maybe they're asymptomatic or have a mild condition that they didn't know that they had. And then another argument is that this could be overwhelming people with too many options, which I think it can be hard because there are so many different panels in general, but it could be hard for people to decide whether they'd want to do over 200 conditions. And the more testing you do, the more genes you add, the more likely we're going to have positive results. So with expanded carrier screening of around 300 diseases, we find that about 70% of people come back as a carrier for at least one disorder. So all this background is really to move into some newer testing options. So before we talked about the different reproductive options that a carrier couple has, I've had a lot of couples come and ask, during a pregnancy, are there any non-invasive testing options? I don't want to do the CVS or amnio because there's a risk of miscarriage. So within the past year, there are 2 labs that have come out with technologies or non-invasive testing options for these conditions. And just a brief review about what is non-invasive prenatal screening. It's also called cell-free DNA screening. It's a screen that's offered in pregnancy where it's measuring fragments of placental DNA that are circulating in the maternal bloodstream. It was clinically came into practice in 2011 and first targeted for high-risk pregnancies for the most common chromosome conditions. So that would include Down syndrome, trisomy 18, and trisomy 13. This screen has really high detection rates for those conditions, ranging from 95 to 99%, and low chance for false positives. So 0.2% for Down syndrome and about 1% for trisomy 18 and 13. The blood draw can occur at 10 weeks gestation or any time after. The turnaround time is quick. It takes about a week to get those results back. As it's a screen, there's a chance for false negatives and false positives. So if there's a positive result, you want to recommend genetic counseling and option for diagnostic testing. And this is just an illustration to show you how cell-free DNA screening or non-invasive testing is working. So as you can see, when the placenta or those trophoblastic cells are undergoing apoptosis and releasing fragments of chromosomes into mom's bloodstream. So in mom's bloodstream, she has her own, of course, genetic material or chromosomes, and then chromosomes coming off of the placenta. So there's different methods a lab use, but most commonly they're just counting to see how many of each chromosome they're seeing. Or is there any overrepresentation of things like chromosome 21, which would indicate Down syndrome? Limitations are that we're only looking at the placenta, we're not testing baby directly, and sometimes you can incidentally pick up that maybe mom has those chromosome abnormalities since you're also looking at her blood. But all to say, since we can get this kind of sample, we are now able to test for single gene disorders or monogenic disorders. So this is helpful for carrier couples who do want prenatal testing. We can screen baby to see if baby has the same mutations that parents carry and learn if they're carriers of the condition, not a carrier, or if they're affected. So a lab called Progeny introduced their brand name test called Resura in 2019. It's a customized cell-free test for recessive, autosomal dominant, and X-linked disorders. The blood draw can also occur anytime after 10 weeks of gestation. It is a 3-step process right now. Since it's customized, the lab has to review the case, which takes about 2 weeks. And then the second step is to get mom and dad's blood samples as a control. And then step number 3 is the actual prenatal test. So another really big benefit of doing carrier screening before pregnancy is if you know they're a carrier, you can talk to them about their options. And if they wanted to consider this option during a pregnancy, you can do the first 2 steps and have everything ready so that the blood draw can be done right at 10 weeks and we can get results within a week or 2 after that. The lab released their study for Resura. They validated the platform with a study of 57 women, and they reported greater than 99.9% sensitivity and specificity. And then so 53 of the 57 tests that they did, they were able to confirm postnatally, that either the fetus was affected or not affected. And some of the samples failed to pass their quality control, so that's why the reportable rate was only 92%. And then lastly, there is a lab on the West Coast called Avrio. They have a new branded test called Unity, and their strategy is a bit different. So what they're doing is they're recommended carrier screening, and this is a test done during the pregnancy, looking for cystic fibrosis, spinal muscular atrophy, sickle cell disease, alpha thalassemia, and then other beta thalassemias. And then if female patients found to be a carrier for one of those conditions, they automatically reflex to doing cell-free DNA screening to screen fetus for these conditions to see if they're affected. So they're able to look for mom's mutation. They don't know dad's. The idea is that you don't even need dad for this test, but they're looking at the common mutations for the set of these disorders. it is a really quick test. So with the carrier screening and then the cell-free, it takes about 2 weeks to get done. And again, the way they design this test, they say, the reason to do this and consider it is that half the time when a female patient's found to be a carrier, dad is unavailable for testing or doesn't get the follow-up due to financial and logistical barriers. So kind of removing him from that step. So if you think about it, if you were to do carrier screening for a female patient during a pregnancy, let's say she came in at 11 weeks, by the time you did her carrier screening, dad's carrier screening, and then test the baby, if they were a carrier couple, that would put them at around 20 weeks or later, whereas this would be done in about 2 weeks. And then the right is showing an illustration of how this is working as well, very much simplifying it. I'm definitely not the expert on the methodology, but they amplify single base pairs and compare them to a control. And again, are just counting to see what SNPs are present to tell them whether baby's unaffected, not a carrier, or affected. Okay, so that is all I have for my part. So I will show my references, and then we can transition to Kestutis.
Just gotta end your screen share.
I just can't find the main screen right now for some reason. Here, stop share.
Okay. All right. So, yeah, kind of the second half of this presentation, we're going to change gears a bit and go from prenatal screening for common genetic disorders and really doing non-invasive screening for that as well, to kind of going very other end of the spectrum where we're doing pretty in-depth testing for rare genetic disorders that pop up. So this will kind of cover prenatal whole exome sequencing, and I'll be giving a kind of high-level overview on whole exome sequencing, and then presenting a case that I think kind of really highlights some of the benefits and limitations of this type of testing. So, I feel like it'd be kind of remiss to not bring up, of course, your basic genetic, some of the genetic dogma of, chromosomes containing those DNA sequences, which have genes along them, and those genes, of course, made up of those letters and everything there to produce those protein products. And so focusing on a gene specifically, of course, we see that a gene has a number of elements to it. Promoter elements that help regulate whether the gene is being expressed in creating that protein product or being turned off, as well as exons and introns within the gene. So those introns being spliced out of the final mRNA product, whereas the exons go on to actually become the coding and kind of amino acid sequence, which then becomes that protein in the long run. And just wanted to briefly mention that because, of course, with whole exome sequencing, we're focusing just on those exons. So in this image here, just those yellow and not the gray areas. It's important to remember that because it does create some limitations in whole exome, even if it is considered the most comprehensive test we have available from a prenatal perspective. Of course, in the pediatric world, they've moved quite a bit more towards whole genome sequencing as well. But whole exome sequencing, of course, is just looking at those exons, so just what is creating that final protein product and the mRNA, the products as well. This exonic sequence that we're sequencing with whole exome is about 180,000 exons across 20,000 genes. But it sounds pretty amazing, but at the same time, that's only about 1% of our genetic material that we're actually looking at. Granted, studies have shown that 85% of pathogenic variants are located in the exons. However, I'm sure that number is going to change because that was based more so on the before we started doing whole genome sequencing regularly. So I'm sure as we start finding genomic variants, that number might change. But that was the most up-to-date one that I had, is that exons really are the best place to look for those genetic variants. And the other thing to remember too is that it is a phenotypically driven analysis. So whole exome sequencing works a lot better when you have a fetus, or in the pediatric setting, a child that has some sort of symptoms, and then you're trying to find changes to explain the symptoms rather than using it beforehand and kind of prognostically, and trying to ascertain what might happen down the road from a healthy child. Other things to consider with whole exome sequencing is that this is performed on the nuclear genes, so we're not doing RNA sequencing. This isn't sequencing the DNA within the mitochondria either. And with any genetic test, there are regions of our genome and within the exons that are more difficult to sequence. So things like trinucleotide repeat regions, pseudogenes, GC-rich areas. It's hard to analyze that information, and obviously this doesn't substitute, this is not a substitute for things like karyotype or chromosomal microarray, where we can pick up copy number variants and those deletions and structural variants that can occur within a chromosome itself. So it does work very well in tandem with karyotype and microarray. And so what we see in the prenatal world is that in an anomalous fetus, karyotype and microarray can have a detection rate of about 27 to 40%. Obviously, prenatally, a lot of that is going to be aneuploidies, Down syndrome, trisomy 13, trisomy 18. Sex chromosome aneuploidies are just far and beyond the most common things. But in fetuses with normal cytogenetic testing, so normal karyotype and microarray, some of the initial data on whole exome sequencing in the prenatal setting was showing quite the range of detection rates, so 8.5 to about 80%. And that was depending on the study and how selective they were. So in this 8.5%, the study was just doing whole exome sequencing on really any fetus with, even just a single anomaly. And that 80% is from a small cohort where that was highly selective, so anomalous fetuses. And one of the criteria for that was also consanguinity. So of course, the rate of autosomal recessive conditions is increased there. Some of the newer studies that are coming out, in the past year, a few months or so, are starting to hone in around 30 to 40%, which is starting to mirror that of what the detection is in the pediatric setting. So in pediatrics, it's become pretty well established. There's a 25 to 30% detection rate for kiddos that have multiple congenital anomalies and or some sort of learning, intellectual, developmental delays. So in the prenatal world, we're kind of settling in around that as well. It does vary depending on where the anomalies are in the fetus. So things like skeletal dysplasias or central nervous system anomalies tend to have higher detection rates, whereas things like congenital heart defects still quite low on finding a variant in whole exome sequence. So what are the advantages of looking at all these genes simultaneously? Well, we can get information about the fetus within a faster turnaround time. We do have turnaround times, that are coming back within 2 to 3 weeks of sample send out. So pretty good. And it is faster than kind of doing it stepwise of looking at your cytogenetics, looking for a panel, doing targeted testing, kind of getting everything done at once. So having that information, of course, facilitates the parent's ability to make decisions regarding management or whether or not they want to carry a pregnancy to full term. also thinks about, how can we apply current or future fetal therapies? So if we're making diagnoses via whole exome sequencing early in a pregnancy, is there potential that we can provide treatment even before a baby's born that can drastically improve outcomes as well? Um, Once again, directing the NICU team for a lot of these kiddos that have anomalies of how they can best manage this baby. Are there other scans, imaging that we need to do after delivery? What does it tell us about potential lifespan of the baby? Are there things that we need to look for after birth? Um, Additionally, thinking about future pregnancies, this is really true of sequencing in any time period, but if you can find a genetic diagnosis, it'll tell you, what are the family's odds for this happening again? Which then goes into doing IVF pregnancies and testing those embryos for that. Additionally, because prenatal whole exome sequencing is very new in the prenatal setting, it has allowed us to identify a lot of genetic conditions that were typically classified in the pediatric setting. And now that we're able to apply this technology, we're getting earlier diagnoses and able to start thinking about what are features that we might see prenatally that we didn't know about for conditions that we typically thought of as a pediatric condition. And so doing this early testing has helped us with some of those early diagnostic information and kind of filling in some of the blanks about what types of things can appear for that. So quite a good list of advantages of doing prenatal whole exome sequencing, but of course, in the prenatal setting, it's not without a lot of limitations as well. And so the biggest thing that whole exome sequencing struggles with is the fetal phenotype. And that's one just really emphasizing that that's very difficult. Fetal MRI, fetal ultrasound, fetal echocardiograms have gotten very, very good and continue to improve year over year. However, those modalities are still, insufficient compared to looking at a baby face to face, or even doing imaging directly on a baby. A fetal echocardiogram is, not quite as good as doing an echo right on the baby after birth. And so that means we're going to miss some findings. There's going to be things that we can't see in a baby before they're born that we can assess after delivery. And part of it too can depend on how comfortable providers are with some of these fetal findings. On ultrasound, certain things can look very similar and be missed or be misclassified. Things like MRI, which is fetal MRI, which is not necessarily, which is definitely not universal in the OBGYN world, provide much better detail on brain findings than an ultrasound ever can. And so for that reason, if there's brain findings that might be missed on an ultrasound, but picked up at kind of down the road or something like that. And so those are all important pieces of information that may or not be able to be identified, but are crucial in helping interpret those whole exome sequencing results. Additional concerns that we have in the prenatal setting are the sample quality. Did we get enough sample from a CVS or from an amniocentesis? Does that sample culture for us? Was there any maternal cell contamination in which some of our mom cells got into the sample and might throw off those results a little bit? So important thing to consider there versus doing a blood draw or getting a saliva sample in which you can have good quality and access that sample or get more blood at a later time. It's hard. A lot of patients don't want to do another CVS or another amniocentesis if they don't have to. So you kind of get what you have to work with, and sometimes the sample just isn't great. So I kind of mentioned some of the technical limitations of whole exome sequencing at the start. There are just certain regions in genes that are hard to sequence, or because of pseudogenes where genes look very similar, it might not pick up certain things, or certain genes just are really hard to analyze from a sequencing perspective. Additional technical limitations can include depth of coverage, as well as what's the variant filtering or interpretation pipeline that the laboratory is using. If the laboratory has that dropout that should be included in the analysis, or giving you too many like variants of uncertain significance back that kind of need to hand interpret in a way. So those also can affect how applicable prenatal whole exome sequencing and just like the scientific knowledge, because the fetal phenotype is often incomplete. I think getting a huge VUS results make it extremely challenging. Give a family information about what a potential diagnosis could be. Are there other things that we should be looking for? Did we still miss something? So those VUSs in the fetal world are more pesky because they do a lot of anxiety in parents, and especially in the sense that it's hard to tell me that we found this genetic change, but we don't know it, and therefore we don't recommend any clinical management decision making from that. So if we find a VUS, we don't need to use that as part of their decision making for whether or not to carry a pregnancy to full term, because that variant is likely be benign as it could be pathogenic. We try to clarify things as much as possible, but with limitations of what we can in the fetal phenotype, coupled with what we currently know about various variants and even genes of uncertain significance, it just becomes hard to sometimes deal with some of those uncertain results for families. Turnaround time can still be quite a difficult thing to balance. A lot of times we're doing whole exome sequencing after the anatomy scan and after we have found fetal anomalies. First year of testing is still going to be cytogenetic testing, karyotype and microarray. We still need to do that before whole exome sequencing. Once you factor in, having to culture cells or on top of the sequencing, that turnaround time is starting to push up and even go beyond cutoff for termination in other states. Thankfully, in Colorado, of course, we have that ability to interrupt at any time point in a pregnancy, but it does become much harder to do with much more expensive later after 24 weeks. Cost is also a big factor for families. Whole exome sequencing, I have not seen any covered by insurance yet in the prenatal period. It's still considered experimental, and so a lot of these families are facing out-of-pocket costs for this. Prevention Genetics does do a proband only for $2,000 about, which is about the cheapest that it goes, but I think typically we are looking at about a $3,000 to $5,000 expense for families that they'd have to pay out of pocket to prenatal whole exome sequencing, even if it's very clear that it would be useful. Sometimes there are better testing options, to be honest with you. Some of these whole exome studies that have come out, for example, ones that have studied renal anomalies, they pick up variants in PKD1 or PKHD1 that's associated with autosomal recessive polycystic kidney disease. We could have run a cystic kidney disease panel for that and gotten those results in the same amount of time for less money and would have been covered by insurance. So, whole exome sequencing, it's easy to kind of knee-jerk to that and say, let's cover all of our bases. But at the same time, I think we also need to think critically about what we're offering to families and saying, is there a better option out there or a more targeted panel that addresses the fetal phenotype? Additionally, secondary or incidental findings. So do we end up finding a variant in a completely unrelated genetic syndrome? Or do we find a variant in a BRCA gene that has implications down the road or for other family members? Depending on the laboratory that you use, some do not report that for fetal testing and focus exclusively on reporting only variants that are likely associated with the disease, because that goes down a whole nother wormhole of, what if we do find something? Now we're dealing with a fetus with anomalies and a family that has, cancer predisposition. So that can just add a lot of complexity to those cases. So it's important to figure out what labs offer what as well for that. So kind of have the pros and cons of whole exome sequencing. So who should we be offering it to? And there's a couple policy statements that have come out over the past few years. We're probably due for some updates, but it's a bit wordy of a slide, but essentially current recommendations say whole exome sequencing should be a last resort type of option. So we're looking at fetuses with congenital anomalies, or in some of that recommendations at the bottom here, if there's recurrent pregnancy loss and a pattern of anomalies that still is unexplained, they say that you need to really exhaust all other options. So definitely karyotype and microarray, always first tier of testing. But there's some interpretation that's available in these statements. But I think generally speaking, they do kind of want you to think about what panels, is there a syndrome-specific panel or a finding-specific panel that might work better before we jump to whole exome sequencing for this. So these recommendations are should change, and it's going to be a bit of a moving target as we get more information out there. But essentially, it's last resort if we're still super suspicious of something genetic in a fetus that we don't have an answer for yet. So a good case that we had to illustrate this is we had a 27-year-old G1 P0 come in. She was already 25 weeks gestation and was referred to multiple congenital anomalies. Hopefully you can see my cursor here. You can see there was a left-sided facial cleft that actually extended upward to about the eye, which resulted in left-sided microphthalmia. So you can actually see the orbit here is missing on the MRI, in which fluid is white on MRI, and tissues are varying shades of gray. You can see the right-sided orbit here that's present. There were low-set, abnormally shaped ears, abnormal position of the hands, as well as syndactyly on there, single umbilical artery, GU anomalies, as well as kidney abnormalities. And I think I was trying to highlight that down here, some GU anomalies, just kind of this kind of cystic, I think maybe cloacal looking like anomaly, and not a good, I don't think we had good visualization of at least one kidney, or it was cystic probably. You can see even with the profile that the nose is not very well defined. The upper lip is really missing here with that clefting as well. FISH, karyotype, and microarray for this fetus were all normal. So, that was normal, but with all these findings, very, very suspicious for something genetic still. So we agreed as a team that this would be a good candidate for whole exome sequencing because they didn't really seem to fit a picture for what was going on. And so we did whole exome sequencing. Results came back in 3 weeks. So we're talking about 28 weeks of pregnancy here, so getting further along. They did report a likely pathogenic variant in the PORCN gene on the X chromosome, and also reported a VUS in FREM2. And so the PORCN gene is associated with focal dermal hypoplasia, which is an X-linked disorder. I should say, it's typically male lethal. 90% of the cases are female, but it does have a variety of findings here. The big findings are cutaneous, so you can see the abnormal pigmentation and abnormal texture of the skin. But you can also, what's less commonly and a lot more variable are the limb malformations. You can have ocular findings such as microphthalmia, craniofacial abnormalities such as that cleft lip and palate. Usually these fetuses and children are very small. And then renal genital abnormalities and some degree of cognitive impairment. It is quite a variable syndrome though, and varies quite a bit from person to person. The FREM2 gene, of course, associated with Fraser Syndrome, which would be autosomal recessive. So we only found one variant for this. Typically a lethal condition, but you can see that a number of the findings do overlap with this fetus as well, with eye abnormalities, facial abnormalities, the syndactyly, GU, and renal anomalies as part of that as well. And then some clinical photos of what, some textbook photos of child with Fraser syndrome here. So ultimately, we have these two variants that were identified and reported by the laboratory. How do we interpret this? So we have these two syndromes, focal dermal hypoplasia versus Fraser syndrome. These syndromes, some of the key findings associated with them really are difficult or actually impossible to find on prenatal imaging. So the skin pigmentation abnormalities associated with focal dermal hypoplasia, unless you go in and put a scope into the uterus and take a look prenatally, which I don't see why you would do without needing to do fetal intervention, you can't see those skin abnormalities until the baby's born and you can do a clinical exam that way. We just can't detect any sort of skin abnormalities on any sort of imaging modality. Additionally, things like cryptophthalmos, can be pretty hard to distinguish on prenatal ultrasound and MRI. Just facial features in general can be really hard to find some of those little subtle nuances and shape of things. And even ears are hard to assess before a baby's born. So, some of these key findings associated with these conditions, we just don't have, a good idea as to whether they're there or not there. So we still are waiting to do an exam after birth in this scenario. Additionally, we have Fraser syndrome, which is recessive, but we only found one variant, which means there's a second variant that needs to be present. That first variant was also a VUS. However, when you look at the clinical sensitivity and testing sensitivity for Fraser syndrome, we only find pathogenic variants in about 40 to 45% of cases. So only finding one variant, you could consider wouldn't be an uncommon scenario with how poor the sensitivity is for this genetic syndrome. And so are we looking at a scenario where there is a second variant and we just can't find it because of our testing methods? Hard to say. So then that means kind of moving on towards outcomes, then how do you counsel the family? We have one genetic syndrome, focal dermal hypoplasia, which, in females, this is a female fetus, not necessarily lethal, can have good cognitive outcomes, but is hugely, hugely variable in those expectations due to that X inactivation and which copy of that PORCN gene gets inactivated in that process. Additionally, we have Fraser syndrome, which is typically lethal, but appears less likely because we're missing a variant and maybe the clinical features don't line up quite as well as we would like. So at the end of the day, we have these whole exome sequencing results, but ultimately, still not a clear-cut diagnosis. It wasn't the end-all be-all, and the family still had a lot of their decision-making driven by the fetal findings that we were detecting prenatally. And the sheer number of those findings, the couple did decide to pursue comfort care, especially with that large facial cleft, which, like I said, really extended from that upper lip all the way up to that left eye, and would have required quite a bit of surgery there. And so they ultimately decided to pursue a comfort care route for that. And when the fetus was born, it actually became pretty apparent what the diagnosis was. And you can see all the different areas of abnormal pigmentation in this fetus, which says this is focal dermal hypoplasia. This is one of the key criteria for diagnosing that. Subsequent testing revealed that it was a de novo mutation. And so the couple was counseled that there was a less than 1% chance for this to occur in the future pregnancy. And at least they had kind of that to hold on to given kind of their experience with this pregnancy. So I think some of the takeaways with whole exome sequencing is that it is highly specialized testing. It has a lot of potential for it, especially in the prenatal setting. We're learning more and more about it. It has a lot of application, but there is a lot of limitations to it still. And one thing that I didn't really go over in a lot of detail is that it does require a lot of pretest counseling just because of the sheer volume of genetic material that we're analyzing. And kind of like carrier screening, like Hannah had mentioned, with some of these expanded carrier screening panels, people think that they've gotten all the testing possible. And it's really important that, whole exome sequencing is great. It covers a lot of stuff, but, there's still a lot of things that it can miss. And so, it's important to really emphasize that to families that genetic testing is kind of always this odyssey that continues onward. Even now, we're still, with new studies coming out, still kind of figuring out who is a good candidate for whole exome sequencing. What's our timeline for that? How can we help cover costs for family? Things like that are all questions that need to be answered because, it can be prohibitive that way. So it is important still that whole exome sequencing is a tool in your toolkit, but it's also, very, very essential just for helping the family also think what are other options available to us, especially considering some of the limitations that we have prenatally and what we can and can't see in a fetus. And so I think we're going to see a lot more studies about this in the coming years, and I think this will just continue to grow, and we'll have more and more information to be able to refine, who gets whole exome sequencing, who gets more targeted things, and getting those costs covered for our families as well. It's a list of references, and I can stop sharing, and I think we are good to move into any questions.
Yes, thank you so much, Kestutis. We did have a couple of questions come in from our audience. The first one is considering that you cannot test for all the mutations for a specific disorder, for example, cystic fibrosis, do you do Bayesian calculation to send the risk to the patient you're testing?
I can answer that. That's a good question. So once carrier screening is done and someone's results are negative, meaning they didn't find any mutations, then there's a residual risk that's reported. So, we're reducing the chance that that person's a carrier, but we can never eliminate that risk completely. So the lab's actually going to give a table with a genetic condition and then the residual risk if negative and based on ancestry as well.
Thank you. One other question, do couples often disagree about prenatal testing and how that is handled?
Yeah, I think it depends. There are some couples who might have a more difficult time deciding which test option is best for them and what they would do with those results. So I think in the end, people tend to agree. It's the question of, are they on the same page from the start? Will it take them some time to make those decisions?
Great, thank you so much. We're just going to hang out for a couple more minutes to see if we have any additional questions come in by chance. All right, looks like we have one. Do some couples request to not know all results of prenatal testing, for instance, regarding certain adult onset conditions?
Yeah, so with whole exome sequencing, obviously that's something that can come up. Depending on which laboratory you use. So I know Baylor does whole exome sequencing and GeneDx, and they do more of an opt-out for those types of conditions. Prevention Genetics does not report secondary or incidental findings prenatally. So if you're using one of those labs that is reported or is a potential thing that they'll disclose, it is important to counsel those families on that, make sure that they are making an informed decision to have that testing or to opt out of it as well. So yeah, that is an important thing to counsel families on.
Great, thank you, Kestutis. We have a question from Karen Byrne Essif. She wants to know, do you know the cost of AVRIO and is it covered by healthcare plans?
So insurance is not covering cell-free DNA screening for these single gene disorders at this time. Still considered investigational. Hopefully that will change. I'm sure just become more adopted later on. I don't know the specific cost for AVRIO lab. I do know that Progenity, the other lab that does the customized screening, theirs is around $3,000.
Okay, thank you so much. Thank you to our few audience members there for your questions. Those were very helpful, and thank you for responding to those, Kestutis and Hannah. I guess I'm looking here, and it doesn't appear that we have any additional questions coming in. So I'm happy to go ahead and wrap up the rest of our session. But if anyone should jump in, you're more than welcome to submit your last final questions. Again, I just want to thank our presenters, Hannah and Kestutis, for sharing their expertise. And thanks again to our audience for joining.